Thank you so much, Mark, and thanks for the invitation. It's great to be with you. I like to teach, and one of the things I'm used to doing when I teach is walk, but I've been instructed that I've got a box back here that I get to stand in. So I will be meeting you from here and hopefully engaging you in a conversation that's of interest to all of us. So I want to speak with you about the concepts around complement and specifically with kidney disease. Before I do that, a couple of disclosures. I am an advisor for Alexion, which makes eculizumab, and Allossure, which makes a separate cell-free DNA assay. In the past, I did work in Richard Smith's laboratory at the University of Iowa, which is a complement lab there. And so I just layer those out as we continue the conversation. I also love cross-country skiing, and one of my goals is to see the forest through the trees. So let's talk about some of the elements of clinical and pathologic features of various complement-mediated renal diseases, including TMA. I want to try to provide in that conversation a classification for when to use complement testing and when not to, and identify appropriate therapies for various forms of TMA syndromes, knowing that right now many are not available for use in clinical realms. So I thought I'd start with the ever-present challenge of the complement pathway. And it's exciting. It's also more complex every day. And I even have to remind myself of what it actually is, depending on what we're dealing with day to day. Historically, it's been taught that we have a classical pathway, a lectin pathway, and an alternative pathway, with the classical pathway being activated by antibody-antigen and complexes, polymers of various forms, all leading to the C1 breakdown and down the pathway. Lectin pathway is separate and often is activated through microbial molecules. Pattern recognition pathway is often partly through that, and that can be mannose binding or other. And then microbial molecules of various forms, including polysaccharides, have been shown to activate the alternative pathway directly. I think that that's an ongoing question of how we can best understand direct activation of alternative pathway. When that happens, there's an ongoing tickover of the alternative pathway in a soluble form that can lead to C3 activation if not regulated well enough. So one of the things that I do want to talk with you about using a number of cases today is how the various pathways can be activated and at times dysregulated. We also know that complement is a ubiquitous and ancient system within the immune system. And I lay this out not because we're going to walk through it, but rather just to reflect on how interrelated the complement system is to so many other parts of our body's functions, whether it be inflammation and resolution and repair of various injury. The adaptive and innate systems of interface are obvious to some extent, but continue to be laid out in more clear fashion over time. And then separate from that are coagulation factors and coagulation cascades that we'll definitely acknowledge is increasingly known to be interrelated. I thought we'd try to simplify the conversation about how the complement system's role is usually known. And it has relations to our ability to note and sense a microbe or some form of external injury or external stimuli that then leads to opsonization by attachments of various complement proteins that in time lead to the capacity for anything from immune system stimulation of B cells or T cells to phagocytosis to lysis of those organisms. Surveillance of apoptotic cells are another component of a normal role of the complement system, where pattern recognition receptors will then activate the phagocytosis of various cells that have either apoptosed or potentially necrosed, while trying to maintain healthy cells through regulation. And those regulatory pathways and regulatory proteins are necessary for ongoing health. And sometimes that doesn't happen. And with that, a disease cell may lead to amplification of the complement system, leading to opsonization of normal cells, including, in this example, T cells, platelets, and through that, death of those cells when they normally would not be killed. Over the past, I'd say 10 years, maybe 15, there's been a notable rise in interest in complement in various areas of medicine. And the diseases involving complement have just really grown. You'll see here in this figure, I think, a helpful outline of systemic and local involvement of complement, along with the acute to the chronic involvement. We have knowledge that sepsis and trauma have long been activators of complement. In addition to that, hemodialysis, which we do on a regular basis to keep people alive, is known to activate both the classical and the lectin pathways. C3G, TMA are examples of either excessive activation or inappropriate regulation. And finally, lupus is an example of ineffective clearance of complement in that situation. You'll also note some local diseases that include transplantation. And at the end of this conversation, if we have time, we'll talk about how important ischemia reperfusion and antibody-mediated rejection are as examples of activation of complement. So for our first case, this is a woman that I cared for a couple of years back who came in with no past medical history and had 2 days of crampy abdominal pain and diarrhea. That evolved into fevers and bloody diarrhea 8 times within 24 hours. She had been healthy up until this and had just returned from a trip to Victoria, BC, where she had had a breakfast burrito and a turkey sandwich from a grocery store, grilled hamburger, and a taco from a truck. And those all became relevant as we went through this conversation. Nobody around her was sick, and nobody else had symptoms like she did. On examination, her vital signs were normal when she first presented. She was tired but otherwise okay, and on rectal exam, she had frank blood mixed with stool. Remaining part of the exam was quite normal. When we first looked at her laboratories, her white blood cell count was elevated at 14,000, but otherwise pretty normal BMP and CBC. You'll note that she had some blood in the urine, and that was on the dipstick, along with ketones. The emergency room, as usual, did a CT scan, and they found colitis along with pericolonic stranding, concerning for pretty profound inflammation. So she was admitted, and over the next 3 days, she had persistent abdominal pain and fevers, along with a drop-off in urine output. Her family also noticed that she just wasn't quite as clear as normal. Additional lab tests came back in that 24 hours from admission on, including an LDH that was up to 900, haptoglobin that was undetectable, and a CRP that was quite elevated. So this had a lot of people concerned. And so there was obvious concern for a possible Shigella or E. coli associated infection, and the initial toxins were sent off, and the first results came back negative. So the question was, what do we do in this situation? Well, we didn't get called as nephrologists until things changed for the worse. You'll note that her white count had already started to rise. Her platelet count had quickly started to decline. And not surprisingly, then the creatinine, 5 days in, started its marked upslope. So we were called and hematology was called. And without question, it was quite obvious that she needed to have support, both in terms of what was likely an HUS, while also the concern for ongoing and progressive kidney injury that was fast enough in nature that she was having hyperkalemia and acidemia that needed to be addressed. So she ended up with both plasma exchange and hemodialysis on a daily basis from that day 5 forward. We were able to send her assay of stool to the VA, and about 3 days after the first test came back negative, then the second test came back positive for Shiga-Toxin type 2. And thankfully, we have some great colleagues at the VA that have capacity to do additional testing that sometimes isn't possible. This was actually a DNA test that was available only through their lab for reasons that I can't necessarily understand. You can maybe teach me how that worked out. But I was thankful for the diagnosis, and yet we still had a concern with regard to her prognosis. So she had clear thrombotic microangiopathy, where she had microangiopathic hemolytic anemia, thrombocytopenia, and associated organ injury. The pathologic features that we normally see with this include arteriolar and capillary abnormalities, specifically intimal proliferation, endothelial swelling. The schistocytes that then get lodged in there lead to a microvascular fibrin and platelet-rich thrombosis. And this is an example of how her kidney would have looked if we had biopsied her. There are a number of associated systemic disorders with thrombotic microangiopathy, and I guess I want to step back and name that there are cases such as the infections that we're talking about here in this case, along with DIC for other reasons. Severe hypertension is associated with TMA. Cancers and tumor emboli are strongly associated with TMA in the right setting, whether it be local or systemic. Autoimmune disorders we know about. A number of pregnancy-associated disorders, including severe preeclampsia and eclampsia, along with HELLP syndrome. And finally, hematopoietic stem cell and organ transplants have a variety of reasons for TMA. To think about it in a slightly different way, this figure from Nestor and George back in 2014 I found to be helpful in that they broke down the various forms of primary TMA syndrome, including hereditary TTP or acquired TTP. Separate from that are complement-mediated, both hereditary and acquired TMAs. Independent of that are drug-associated, both immune and toxic-associated TMAs. And then finally, there are some both metabolic and Shiga-Toxin associated. So all of those are considerations. And as I approach the concept around TMA, I often find that we, as clinicians, are presented with the TMA as a condition first, and then the question is what caused it. So if we know that one of those factors is a player, we may be able to immediately jump to the underlying disorder and address that. At times we don't have that answer, and so we need to ask the question, what may be going on? The first question I would ask is whether there's acute kidney injury or a sign of that. And that allows us to then look at if there's not or no clear kidney injury, then maybe this is TTP, and we surely need to get an ADAPS-TS to clarify that. If there is a sign of kidney injury, then the question of acuity and age of the patient comes into play. And that's based on the fact that there are a variety of separation components to when someone has a sudden onset versus an acute or long-term onset. That helps to define the likely cause. If it's sudden, it's more likely to be an immune response to a drug versus an acute onset, meaning within days, it's more likely to be either a Shiga-Toxin associated HUS or maybe an acquired complement or hereditary complement disorder, and we'll talk more about those. Separate from then the coagulation association, which is more often the case in children. Finally, we can see metabolic associated abnormalities, mostly with B12 in children. A long-term consequence that we'll talk about is also kidney injury in the setting of drugs from a toxic point of view. So briefly, if we think about the fact that this patient showed up with signs of TMA, most likely HUS, she then had a component of a variety of intramolecular or intracellular components that were changing quickly within her body, leading to Shiga-Toxin retrograde trafficking and ER stress and inflammation, all downstream leading to endothelial injury and TMA. I'm not an expert in this, but having read about and worked with my great ID docs here, they have taught me that the most common situation that we can see is E. coli associated exposures, most often in the summer, maybe with farm animals directly or undercooked meat, and finally in an underdeveloped condition or an underdeveloped setting, maybe contaminated water. Regardless, it leads to a situation where ingestion of that bacteria leads to colonization of the large intestine, which then leads to toxic release, and finally bloody diarrhea and kidney failure. All of that typically within approximately a 5 to 7 day window of time. Now, not everybody will develop that bloody diarrhea and kidney failure. Typically around 25% at the most of patients who get exposed to E. coli will end up with that full TMA-associated HUS. Interestingly, I find that both insensitive cells, as they've been defined, and sensitive cells have roles to play in the pathogenicity of Shiga-Toxin-mediated HUS. If they're insensitive cells, such as a situation where the cells take up the Shiga-Toxin, through that process, their endosomes take it on, and Shiga-Toxin ends up getting degraded by the lysosomes. That happens, unfortunately, then with cell activation and inflammation. That cycle of inflammation proceeds to then activate von Willebrand's factor, and through that, more clotting. On the sensitive cell side, there's endocytosis, but then across time, that the Shiga-Toxin moves into the Golgi apparatus and then the ER, and then translocates back into the cytosol, where it can actually cleave RNA and inhibit protein synthesis, all leading to cell death. And that's most often seen in endothelial cells, mesangial cells, and epithelial cells, which ironically all are found in the kidney. And so I think that's one of the examples and reasons why the kidney is quite a common bystander for this kind of infection-associated injury. Kidney is not the only area of the body that can be hit by HUS, including neurologic signs and symptoms in about 20% of patients, like this woman who had confusion. Cardiovascular signs and symptoms can be found. We talked about the GI symptoms, and sometimes others, including the liver and the lung. If we think about the kidney for a bit more, we know that renal tubular injury is common in the setting of a variety of complement activation conditions, and this is an example of that, where normally we would have factor H as a regulator of the complement system, along with MCP, limiting any engagement of the complement system with those tubular cells. But with damage of those tubular cells, there's a release with MASPs and C3 convertase into a cycle that leads to then the MAC complex depositing on the cell, killing that cell, and only over time can those renal tubular cells regenerate. I mentioned earlier that complement is directly integrated with coagulation cascade. And while I don't anticipate walking through this entire cascade, I just want to name the fact that in this case, this woman who had bacteria as an exposure early on then led to lysis of those cells and DAMPs that then stimulated the complement system itself, while also at the same time the complement activation led to MAC complex deposition, and MAC complex deposition is one of many ways that coagulation cascade gets stimulated, so that there's multiple factors that lead into a more downstream effect and activation, all of which creates a cycle, a vicious cycle. So in this case, the simplistic form of this approach for this patient was she had TMA, she had acute kidney injury, her ADAM-TS13 activity was greater than 5%, so it didn't look like she had TTP, and she had a positive Shiga-Toxin. So that treatment for her included aggressive volume repletion, blood pressure management in the setting of her kidney injury, surveillance per se, and attention to her neurologic and cardiovascular health, dialysis as needed, and at the same time not using antibiotics in order to limit and the recovery from this. We know that ciprofloxacin has been associated with extension of diarrhea in the HUS condition, so that avoiding that has been more valuable. Anti-Shiga-Toxin antibodies have been tested, and rituximab, I can't even say it right, was in phase 3 trial approximately 3 years ago. It unfortunately didn't get through, and so we don't have an FDA-approved anti-Shiga-Toxin antibody at this point available that I know of. Maybe you can tell me if I'm wrong. So it's a matter of continuing to look for therapies to help limit the disease, including the downstream effect of it. Eculizumab has been trialed at times, including in France, and there are 2 studies that currently are ongoing, from what I understand, one in children and one in adults, using eculizumab for patients with HUS, with the question of whether or not it can shorten the length of time of disease and thereby improve likely long-term outcomes. So this woman came back to the clinic 2 months later, definitely improved, but did have some general fatigue. Her blood pressure was normal then, and her creatinine was better, but still 1.8, which is naturally one of the concerns that we have, is whether or not we can recover as much kidney function for these patients after such an injury. Her CBC was relatively normal at that point, and her urine analysis had 1+ blood, but no RBCs on high-powered field to suggest that maybe she was recovering from, but wasn't fully recovered from her TMA. There was really no indication for us to do further complement analysis of her beyond the C3, C4, as it was initially depressed. But as we treated her infection and she recovered from it, we didn't see that there was an indication in this case to do any further testing outside of those realms. As well, we didn't choose to use eculizumab in her case, in part because she recovered relatively quickly. And in adults, there hasn't been as much evidence as in children that there may be value in that. The C1 inhibitor is an alternative therapy that is now FDA approved, but that wouldn't have any value in this case. So I'm going to jump to another case, and that is a 62-year-old man who had a liver transplant, but then progressive kidney injury and presented with dyspnea, orthopnea, and lower limb edema. This was associated with a 26-pound weight gain and really difficulty to walk. He had been walking many miles only 3 weeks prior to this, and so things had changed. The question was, what changed? It didn't look as if he had any cardiovascular exacerbation. He had an echocardiogram, troponins and EKG were normal. There was no signs of lower limb peripheral vascular disease in some way that was compromising him. And so looking at his condition more closely, it was noted that he had been on tacrolimus and MMF. The liver team had chosen to switch him to tacrolimus plus sirolimus. And then because of problems with the sirolimus level and associated proteinuria, that was stopped and he was put back on tacrolimus and MMF about a month before. His levels had been supposedly 5 to 7, and yet when he was actually looked at more closely, there was concerns that he also was having a TMA, and that was reflected in his very low red blood cell count and a dropping platelet count compared to his baseline. His urine analysis again showed 1+ blood with no RBCs on microscopy, which made us a bit concerned. But there are times where we won't necessarily see serologic evidence for this. And you'll note that his creatinine was up to 2.3. He had an LDH that was elevated a bit and undetectable haptoglobin, which made us more concerned. His LFTs were normal, and his tacrolimus was definitely higher than what it thought to be his level. His blood smear didn't show any signs of hemolysis, and he had a normal C3 and C4 along with a rheumatoid factor. His HCV and HIV were retested just to make sure he hadn't received an infection from a donor, and SPEP, UPEP were normal. So that led to dealing with what was then emergently found. I mentioned an echo. They initially called it normal and then went back to actually find that he had a pericardial infusion that needed to be drained. So that plus pericardiocentesis was done, and he had a kidney biopsy done a few days later because of his creatinine having risen so far. Now, one may say this is all cardiogenic, but the concern was that his CBC and his undetectable haptoglobin made us very worried that he actually had something more than that. And he did. He had multiple things going on, including that he had signs of thrombotic microangiopathy. He had some FSGS, and he had some deposition within the subendothelial space that was concerning for an MPGN-like process. So it was called by our great renal pathologist MPGN, consistent with TMA, collapsing FSGS, and along with that, some chronic interstitial fibrosis and tubular atrophy. All to suggest he had some chronic components to this, while he also had more acute condition consistent with a thrombotic microangiopathy. That led us back to the drug-mediated components of this because we didn't have any signs of an infection, nor did we have any signs of his complement system being dysfunctional in that way. And came to the consideration for whether this was an immune-mediated versus a toxic dose-associated TMA. And when looking across the difference between the two, immune-mediated TMA is typically a very acute response, sudden onset associated symptoms, maybe a neuric AKI can be associated with that. And in terms of care for those, naturally removing the drug is important. Plasma exchange can sometimes be of value, especially if TTP is the associated problem. This patient more likely had a toxic dose-associated TMA from his calcineurin inhibitor. And we note that tacrolimus and cyclosporin are both associated with that. One does not mean that the other will have the same problem. And so oftentimes adjusting from one of those two meds to the other is a choice that is made. I would suggest that if there's a chance of pulling someone all the way off a CNI and trying an alternative agent, that would be a very reasonable option. In this case, the liver team chose to switch him to cyclosporin, and there was no further indication for testing his complement system as it had previously been normal, and we had a drug-associated TMA. Also, there was no indication for eculizumab in this case, in part because there was no complement activation. You'll note that his CBC became more normal with time off of tacrolimus, and his creatinine improved a little bit, naturally naming that he had underlying kidney disease to begin with. So we've been talking about some diseases or conditions that don't always activate complement as much, here's an alternative to that. So this is a 29-year-old woman who I've been trying to care for, meaning one of my jobs is to evaluate people that are potential candidates for transplant. And she came to my clinic a couple of years back with a story of developing end-stage kidney disease of unclear etiology in the context of a TMA that was diagnosed at the age of 6. TGP was then added to her diagnoses a few years later when she was in her teens, and she had undergone 6 biopsies locally over that period of her time. Diagnosis, according to the paperwork, said MPGN, though the etiology for this was unclear, and she had been treated multiple times without effect with prednisone, and the team had chosen to continue on FFP every 3 weeks since 8th grade. So this was now many, many years. And they reported that if the frequency of the FFP was decreased to 4 weeks, that she would develop signs of recurrent TMA. So the question that was asked to us is she a candidate for transplant? If we look into her history a little further, you might be interested in knowing that her family history was really negative for any autoimmune disorder. Her father had kidney stones, but otherwise grandfathers, grandmothers had some cancer that was thought to be age-associated and not of great concern to her. She was working full-time at the same time of dialyzing at home every day and was on 4 medications that you can see there, amlodipine, hydralazine, metoprolol, and furosemide, all for her blood pressure. This was one of her biopsy images with really profound thrombotic microangiopathy across all of her glomerular capillaries. This is something we never like to see, and it left me asking, so what is likely causing this, especially for someone who presented so young and seemingly a quite aggressive course. Her family couldn't describe how quickly she went from presenting symptoms to end-stage kidney disease, but it seemed to be weeks to months, nothing longer than that. So I thought this was an important time for us to ask bigger questions about what her complement system was looking like, both in terms of number of various proteins as well as function. So I called up Richard Smith and I said, Richard, this case is an interesting, different one than I usually run across. Can we send some samples to you? And so he said, yes, let's definitely test. And the first thing we found is that her C3 level was low, while the C3C level, the fragments were high. In addition to that, you'll note that the factor B was normal while the BB fragment was high. And so I put the cascade here for you to be able to reflect on with me, that you're seeing that it seems that there's a problem around the C3 and distal to the C3 in terms of what's happening with the breakdown of C3 and what that means for her complement cascade. I also will point out that factor H and factor I were normal, so that it doesn't appear to be a regulatory protein abnormality, at least based on number, quantitative value of those levels. So then from that point, we decided to ask some questions about activity. And so Richard was able to run a number of activity assays and found that the one assay that was abnormal was the nephritic factor assay. And that would suggest that there is an activation at the C3 level that shouldn't be there. And because of its ongoing activity of one of a number of possible nephritic factors, it doesn't matter whether the C3 level is normal or not, the activity continues, and through that activity, all of the downstream proteins are activated disproportionate to when they should be. So we went from that point to asking, is there a possible genetic abnormality in this woman because she had presented so young? And what we found was that she had 2 likely mutations. The first one, and probably the most significant, was that she had a 3 amino acid deletion in her C3, which is predicted to be pathogenic based on a number of databases that are available for this. She also had a complement factor H receptor 5 mutation that had not been seen before and was of unclear significance. So she had both a C3 mutation that was pathogenic in terms of its inability to stay stable, while also a complement factor H receptor that could also play a role pathogenicity-wise. So if we come back here to the cascade and the interpretation that Richard and the team provided me, they outlined the fact that this 3 amino acid deletion was in a location very close to a previously reported case of an amino acid deletion that caused dense deposit disease. And for those of you who don't know dense deposit disease, it's a very severe alternative pathway complement disorder leading to deposits within the kidney at various locations that often leads to early kidney loss and very frequent and severe recurrence within a transplant if performed. So because of that, there's a lot of concerns that this patient has a mechanism similar to that with decreased C3, elevated BB, and that basically, if you look to the middle of the cascade, would suggest that C3 is mutated in a way that continues to turn over and is not stabilized even with the factor H and factor I being normal. And because of that, the C3 convertase leads to downstream activation of both components on the left and the right of C3 and activating the terminal complement pathway. So if we come back to our pathway for her TMA and ask the question, does she have acute kidney injury? Yes. Is the acuity sudden? Not necessarily sudden, but definitely acute in nature. And being that she was young, it leads us to the question of this acquired complement versus hereditary complement abnormality. I think of the complement system as something like when you or I are sitting in our car up a hill here in Seattle with water on the road, and you're needing to accelerate from a stop position. You need 1 foot on the brake and 1 foot on the accelerator. And if you have too much pressure on the accelerator, you're going to peel out and potentially either go down the hill the wrong way or leave some rubber on the road and end up the hill much faster than you expected. And sometimes that puts you out of control to the point where you have a crash. The brake, in my mind, is the idea that we need to continue to maintain that balance between enough acceleration but also regulation of the movement so that we don't get out of control. And of course, the difference between a red light and a green light is the concept around if we have further stimuli, such as a bacteria or virus that gets exposed to these patients that already have a complement mutation, they're going to end up with a loss of that regulation and all of the dysfunction that leads to further abnormalities in the complement system distal to that. So if we start with spontaneous hydrolysis, for instance, in the alternative pathway, or bacteria or viruses stimulating the C3 and hence the C3 convertase conversion from C3b to C3a, and downstream of that, you'll note that complement factor H, complement factor I, and complement factor B all have different roles. Factor H and factor I are supposed to regulate that and diminish the cleavage frequency, while complement factor B has a role in actually continuing to maintain that turnover. In this patient's case, the C3 convertase was activated to the point where even with normal factor H and factor I, she was continuing to be overly active. And that leads to all of the downstream effects, including injury to the endothelial cells in this example, thrombus formation, and over time scarring. And this is an example where it doesn't matter necessarily whether it's endothelial cells, mesangial cells, or epithelial cells. A variety of areas of the kidney are going to be injured by the MAC complex creating those holes within the cell, and hence all of those cells are going to die, and enough will not be able to recover. So that we end up with a very different diagnosis in this case of either an atypical HUS or in this patient's case, a TMA-associated complement disorder where she had normal Adams TS13, negative Shiga-Toxin, and even didn't have GI symptoms to worry about. And so then the question was whether eculizumab or another complement inhibitor would be of value in her case if we went to transplant. I guess I'd like to step back for a second and acknowledge the important work that all of you do, including providing me and my medicine colleagues with accurate and quick responses to our various requests for tests. And that can include anything from C3 and C4 and CH50, which help us with understanding the general activity and potentially overactivity of complement. To then the question of, are there times where we need to go further with functional assays or genetic assays? And typically, I approach it from the standpoint of saying, first of all, there's no acute need for the results of a functional assay or genetic test. Those are all to help us guide long-term diagnosis and planning. Laboratories across the country have definitely grown into wanting to do these tests, partly to serve the population that is high risk for this, as well as some for-profit companies that are wanting to do it as well. I would say that we have a good number of options around the country, mostly based in the Midwest, interestingly. But I think that as we gain more understanding of the role that complement plays across a variety of diseases, we may find interest in thinking about applications of these functional and genetic assays more close to home. But that's something I guess we can continue the conversation about. Complement assays definitely are increasingly specific, though not necessarily sensitive, depending on the assay that we're looking at. And so I guess I want to name that even if we run the test, if it happens to be normal, for instance, the factor H in that case tells us that the number of the protein quantitated within the blood is acceptable, it doesn't mean it's actually functional in a way that's of value to the patient. Separate from those components of function are naming the fact that we continue to struggle with doing genetic testing is only of value if we have knowledge of the various mutations or variants that are playing roles. And so at this point, what we understand to be about 50% of pathogenic variants of the complement system have been seemingly named. That's an estimate, of course, knowing that we don't know what the endpoint is, what the denominator is. So when it comes to treating a woman like this, we've already ruled out underlying disorders, but we would treat it if we knew it. If she had TTP, we would definitely go towards plasma exchange if it was acute. If there was Shiga-Toxin associated HUS, supportive care would be necessary. But in this case, we're looking at a TMA or an HUS where plasma exchange may be helpful if it's very severe. In her case, she doesn't need so much of that right now, but rather if we were to think about a kidney transplant, could we actually maintain stability of her complement system enough with therapies that are long-term to enable her to benefit from a kidney transplant? If we think about the situation, we really have two therapeutic options beyond plasma exchange for long-term care, with eculizumab being an inhibitor of C5, which then prevents some production of C5a, which is an anaphylatoxin, an inflammatory molecule that has really important normal and abnormal associated downstream effects. At the same time, the MAC complex production is limited when eculizumab is used. That's a great option. Naturally, it's not without a cost. And so an alternative for some patients is even a liver transplant because of the severity of the abnormality, as most of these proteins are produced in the liver. Not all of them, though. We actually know that there's a small fraction of the percent of proteins produced in the kidney, so that if someone were to get a kidney transplant once in a great while, you'll have a variable production from that kidney as well. So if we think about eculizumab, it's been on the market now for a few years. It's relatively well tolerated. There are some downsides to it. It's removed with plasma exchange. It's diluted by other infusions. It does interfere with other therapies if we're trying to treat, say, for instance, a rejection episode. Rituximab, ATG, alemtuzumab would all have interference with this antibody. There's a marked increased risk for meningococcal infection, and so vaccinations are required prior to using it. Also, because of that, prophylactic antibiotics are recommended throughout the course of its use, whether that be 1 year or forever. And then finally, the lack of known duration for some of our patients, like the woman I was talking about, raises questions about cost. These are some dollar figures that I pulled a couple years ago, but seem to be still relevant. Published figure that Nestor and George gave was $614,000 in 2014 for the drug per year. Here at the University of Washington, for 26 doses, meaning 1 year at every 2 weeks, was over $400,000. So I guess I raised the question acknowledging that we shouldn't be using this drug without great recognition that it's costly for society and for the patients, and we need to ensure that we're using therapies that are going to be of value in multiple ways. Because of the complement having a lot of interest, complement system gaining a lot of interest in the last years, one of the areas that I found interesting was the number of drugs that are currently in preclinical or various phases of trials. And you'll note both top and bottom attempts at basically trying to prevent either initiation or amplification of the complement system and or impairment of effector functions of it. And there's a good number out there. I'm hopeful that a number will basically come through all the way to FDA approval. But as our experience has so far led, a majority gets stuck in phase 1 or phase 2 because of safety concerns and how ubiquitous the complement system is. And therefore, when you prevent it from functioning normally, there's a variety of risks that come with that. So we'll see what happens. I guess I'll also name that the C1 inhibitor is a FDA-approved drug that has been used now for a number of various entities more close to my work. It has been used in antibody-mediated rejection because of how antibody-mediated rejection is associated with classical complement activation. If we think about the kidney transplant as an example of ischemia reperfusion and how when the kidney is removed from the donor and then placed in the recipient, there's ischemia and then there's reperfusion. And with that, the change from normal endothelial function where there's factor H, C1 inhibitor, and MCP associated regulation of what's normally happening on the surface of those endothelial cells, that changes when ischemia and then reperfusion leads to either injury or death of those endothelial cells, or pattern recognition molecules engage those endothelial cells, thereby enhancing a response in the midst of inflammation. So with that as an example, I have a 28-year-old man with a history of end-stage kidney disease who got a kidney transplant in 2014, had been on dialysis for a period of time before that, actually about 7 years, and was really eager to get a kidney transplant. Got the transplant, everything went relatively well, and then about, I guess it was 4 years later, his creatinine went up from his baseline of 0.9 to 1.3, and his BUN was a little bit higher. And so one of the things that we've started to do here to guide our therapy and diagnosis of people that might have antibody-mediated rejection is we test their sera for donor-specific antibodies. And we hadn't done that up until 2016 on a regular basis. He didn't show up again in my clinic until 2018 January. So these are the very first time that we tested his sera for donor-specific antibodies. And they were relatively elevated against a number of HLA alleles. So I went ahead and did a biopsy, and with the help of our pathology colleagues again, found that he had pretty profound antibody-mediated rejection with the glomerular basement membrane thickened, along with lymphocytes migrating into and inflaming a variety of areas of his kidney, including his glomerulus and his capillaries. One of the valuable tests that we can do is a C4D test looking at deposition of the breakdown product of C4 on the endothelial cells of the capillaries, and you'll note that all of these are positive because of C4D depositing on the capillaries of the kidney. So we had a diagnosis of active antibody-mediated rejection for which we admitted him, treated him with a combination of plasma exchange and IVIG to try to remove those circulating antibodies, along with methylprednisolone for the inflammation, and followed that up with rituximab to try to target the B cells that were producing the antibodies times 2 doses. And you'll notice that over the course then of approximately 4 months, his DSA did improve from where he initially was measured with regard to the flow cytometry MFI by about half. His creatinine came down to his upper end of his normal baseline of 1.2, and I've continued to try to keep track of him, minimizing his lag time between follow-up, because that's been an issue that, for many people, adherence and engagement of care team matters. So as an example of the antibody-mediated rejection-associated complement activation, if we have donor-specific antibodies, like in this patient's case, they will lead to engagement of the, like here on the endothelial cell, engagement of those antigens on the cell surface, thereby activating complement. And from there, C4 gets broken down, and C4D is one of a number of components that get deposited on the cell surface, but that's not the only one. As you can see here, it's also illustrated that MAC complex, of course, will directly kill those cells if there's ongoing inflammation and activity. So as to think about transplant-associated prevention of rejection or treatment of rejection and complement activation in that setting, I guess I'm pleased to see that there's ongoing attention in that way, but also want to recognize that transplant is a small sphere amongst all the patients that are cared for that might have other reasons for complement activation. So I find transplant to be a model for understanding the immune system while also caring for those people in ways that hopefully can provide long-term good outcomes for them. So as I finish up, I want to think with you about the fact that typically the diagnostic testing for complement disorder is based on the acuity of the illness, the age of the patient, whether there's kidney involvement, along with systemic signs and symptoms. Long-term analysis of ongoing complement activity with functional assays or genetic analysis is typically a step after that. And I do not typically go to genetic analysis until I have abnormalities seen in the first phases, including levels and functional analysis. And then finally, using complement inhibitors where appropriate is something that I think we really do need to publicly name in the midst of the costs that we're taking on if we do that therapy for the patient. So I appreciate your attention, and comments or questions are welcome at this point. Thanks so much.
Can you talk about CD59 and DAFs and whether or not people are thinking that they're kind of downregulated or somehow inactivated to help feed this amplification loop? Are they involved or are they just not involved?
You know, I would say that I have not seen enough evidence to suggest that they're a main player or pathogenic enough that we look to them. Please teach me if you know something more.
Chris, so activation of the classical pathway is, of course, common in other diseases. You mentioned the transplant, antibody-mediated transplant rejection. What about other immune complex or complement-mediated renal diseases or other diseases? Thinking certainly about lupus, mixed cryoglobulinemia, et cetera. Is there a role, you think, for C1 esterase inhibitor in those diseases as well?
There may be. I think that I chose not to delve into all the weeds of various kidney diseases because there's so many that we could spend an hour on each one. When it comes to those that are activating classical pathway, I do think that the C1 inhibitor may be a good pathway. I have not seen evidence in the kidney literature to help guide the use of it, and so it's probably going to merit initially some good test questions that need to be analyzed. When it comes to various diseases, I think lupus is a clear option that we need to consider. MPGN that might be immune complex based would be an option in the short term, with then the question of if we add an inhibitor of C1, could that person recover from their infection if there is an infection playing a role without that pathway playing its normal functions. So it's an ongoing challenge, I think, between what's normal and abnormal in that response. And lupus is probably a good example, or other autoimmune diseases where we could potentially approach it.
Really interesting. You mentioned that like 50% of patients have or 50% of variants were helpful in the clinical course when it comes to the genetic testing. What does that 50% refer to? Is that of patients that get genetic testing, you get a positive result in about 50%?
Correct.
Oh.
So at this point, we're finding variants in 50% of our testing time that are known variants, and typically those are helpful, but we have 50% of the time where we don't know, and then digging into those that we don't know about are cases like this that we need to better understand and report.
If I can ask another question, is there any reason to think that this increased potential for activation of the complement system, C3 or perhaps others, may have a protective role in some infectious diseases or other situations? Is there a reason why the complements are good sometimes? Excess complement activation.
You said excessive complement activation?
Yes,
yeah. I guess it's all in the mind of the beholder, yes. I do think that there is that yin and yang of how strong of a response, and yet I would also name that there's great evidence that those patients, especially younger adults who develop SIRS or sepsis with an infection, often have more activated complement than those who have a lesser active complement response. So, excuse me, I think that while it's valuable to have a complement response, and obviously many organisms have survived because of it over the millions of years that they've had it, I think that the excessive response is often as detrimental.
Hey, Chris, great talk. I was struck when looking at the development of all the inhibitors, almost all of them were targeting C5 and the terminal complement pathway. When you can imagine that a lot of the activity, and both chemoattractive and direct damage might be actually more proximal, especially around C3. So I was just wondering if you could comment on that at all.
I think I can. I think the reason why most companies have chosen to go downstream is because of the concerns that blocking upstream impacts so much of the downstream function that impairing upstream often is either not as effective or leads to too much negative side effect when it comes to impairing everything from C3 down to C5 and the MAC complex, along with the anaphylatoxins of C3A and C5A. So imagine the company that ended up coming out with a C1 inhibitor did so with dose titration that was effective enough to achieve inhibition without also impairing all of the downstream, for instance, MAC complex activation. There is still ongoing MAC complex. Many of those that say are targeting C3, for instance, C3 is so fundamental to components of function that inhibiting it either temporarily or long-term ends up with a question of, if you inhibit it temporarily, is it adequate enough to achieve your therapeutic goal? If it's a longer-term inhibition, likely is going to lead to abnormalities and with regard to responding normally to an exogenous stimuli that comes later and the side effects from it.
Well, again, thank you very much for a very nice talk and illuminating and interesting and clearly lots to learn. So thank you so much again.
Thanks, Mark.